so as many people as possible have the benefit of this conversation. So welcome to Healthy Athens, the work group for Envision Athens focused on health, and our specific priority action together is actually in the chat box. So working together to provide substance use disorder prevention and awareness, increasing coordination of and access to supportive services for people living in recovery. So many thanks to Larnie McCarver, who did an excellent job of leading us in recovery messaging training last month. I don't know if you've put your specific unique messages to use, but I think we've actually already had opportunity to use some of those. And actually that's the perfect segue into the next item on the agenda, which is John providing an update on the growing naloxone access and training.
Yeah, hey everyone, we've had some exciting opportunities. First, I know some in the UGA realm that we've discussed, partnering with a number of student organizations to increase the health literacy and education of students on campus. So that would be just for students to know what naloxone is, know how to get it. So folks that could potentially have roommates that use or et cetera, are able to know what naloxone is and have access to it. Overall increase the health literacy of students on campus. Additionally, I was able to present to the Interfraternity Council Executive Board last night. That's all the fraternity chapter presidents, and share with them about naloxone and Narcan and provide more information. So hopefully that's something that they'll follow up on. And then the most exciting, I think, update related to naloxone, Danny, Sarah, and I had an incredible call with Trip Moore, who's the executive director of the Best Western on Millage Avenue. They currently have a partnership with Advantage, as well as with the Athens Area Homeless Shelter, and have a number of individuals that are in transitional housing using their motel in the back of their site. And so they have committed to having their staff undergo naloxone training and carrying naloxone on site. So that's an awesome, I know this group has talked a lot about getting into the hospitality industry, specifically with hotels and motels, trying to increase, at least at the bare minimum, education around it to carry naloxone, and at the most make a commitment like Trip did to have his staff trained and carrying naloxone on site. So exciting update there. We're still working on getting that kind of scheduled and worked out. But Trip also has a number of other connections in the hospitality industry that we're hoping to follow up on, and kind of just use those personal connections to go from motel to motel and business to business, and overall get the conversation moving in multiple places around town regarding naloxone access and education around it. So that's the update I have. Danny or Sarah, if either of y'all have any update you might want to share on that meeting, feel free to go ahead. Otherwise, I'll kick it back to you, Aaron.
All right, I'm looking for your nonverbals and I'm not seeing any, so I'm gonna go ahead. So with COVID, it became clear that, in addition to all of the tragedies and loss of life related to that virus, our community also had to acknowledge the reality of increasing deaths of despair and increasing, challenges with substance use disorder. And so I really appreciate this group kind of coming in strong on one of the things that we could do and did is to engage more assertively in making naloxone and Narcan more readily available, and strategically helping it be placed and positioned in the exact places where it could do the most good and save lives. So I know to date, just since November, there have been 8 reversals and counting, maybe more. And so I just want to stop for just a second. I'm such a person of action. Sometimes it's like, all right, and let's move on. I think that it is very worthwhile, mostly because it is because of the people on this call and not me who made that happen. I want to just pause and celebrate that accomplishment on your part, and thank John and Harrison and Michael and Sarah, really everyone who first made it clear that this was the priority that we needed to address. And then together we really took action with the partnership with Access Point and others to get naloxone where it most needs to be. So I just want to honor your work in that and thank you for your commitment. As we move forward, and I want to leave almost all of our time for the major presentation for the day from our partners at Athens Wellbeing Project. Because of the timeliness and urgency, and because naloxone access seemed like the low-hanging fruit of all of our success measures, that's where we really placed our collective emphasis for the last 6 months. I think at this point, because we gained so much traction in that area, the will of this group seems to be that, you know, we keep doing that kind of behind the scenes, and so we don't stop work in that area. But the primary emphasis of this group moving forward will really be in response to the needs assessment that we're about to learn about. So just trying to help us walk through and prepare mentally for this meeting, kind of being a shift toward now thinking about, as we've made these gains in naloxone access, what is next for this group. So as you listen to the presentation today, I welcome you to be kind of referring back to our list of success measures and thinking about, you know, answering the question, what does our community most need right now? And where do we have the opportunity to have impact? So I want to welcome, first I'll introduce Grace, and then Grace, you can take it away. But Grace, in addition to being a dear friend of mine, is a tenured, Grace, what is your title? It's very, very impressive. Associate Dean
Grace is fine. I'm in the College of Public Health.
Public Health.
Yeah, I'm in public health.
I should have looked it up.
It's fine. No, that's good.
For the purpose of today's call, I think it's probably most relevant that she is the PI for Athens Wellbeing Project. And many of you know that AWP is essentially like the key partner for Envision as we kind of help address the question when we look at data. Envision Athens kind of helps ask and answer, so what? Well, AWP is what provides us the assurance that we know what we know. It provides us the household level representative data to give us confidence that when we think we know what the problems and challenges and opportunities are, that we actually know those things. And so one of our success measures was to work with AWP to conduct a community behavioral health needs assessment. And so they worked hard on that, and happy to welcome you, Dr. Adams, and your team. And I will mute myself at this point.
Thank you, dear friend, for the gracious introduction. Hey, everybody. It's good to see y'all. So good to see some familiar faces. And this is actually my first kind of foray back into work in about 10 weeks in the community, at least. I just had my second child, a son, Theodore. So if you hear a baby in the background at any point, that's who that is. But yeah, I'm so glad to be with y'all today, and just want to start from a place of gratitude. So we have been doing this work for quite a few years now with Athens Wellbeing Project. We really started that in 2016. I was doing community health needs assessment work before that and have done it for over 60 counties in the state of Georgia, focused a lot on Athens and the surrounding counties that our hospitals serve. And this work could not be possible without the team that's here today and so many others, and without each of you, because each of you, as a critical part of the behavioral health service community, really made this data collection possible that we're going to share with you today. So thank you so much. And thank you to Meg and Harrison and Meredith. They're going to introduce themselves, and also another team member, Jacob, who had a loss and was not able to be here today. But I'm just so grateful because these guys actually stepped in and did the lion's share of the analysis that you're seeing today and put these beautiful slides together as I was coming back from leave. So they've done an incredible job under Meg's leadership, and I'm just so grateful. I'm gonna let them introduce themselves and then I'll get started.
Hey everybody, my name is Meredith Lysod. I am a health promotion and behavior student over at the University of Georgia, and I am the spring intern at Athens Area Community Foundation.
Thank you, Meredith.
everybody. I'm Harrison, currently getting a Master's of Public Health and Epidemiology, and I'm an intern with Athens Wellbeing Project.
And Harrison is also a health equity fellow this semester with the city of Young Harris, Georgia. So he is wearing many public health hats. Meg.
I'm Meg Bramlett. I'm a student in the Department of Epidemiology and Biostatistics in the College of Public Health, and I'm the Athens Wellbeing Project doctoral fellow.
So these guys made all this possible today, along with each of you. As I said, we're going to be going through a lot of slides and a lot of data. The slides will be available to you immediately following this presentation because of the diligence of John Morris, always sending out things so quickly. But these slides are for you to use as needed. One of the things that we're creating here is not just knowledge for us to use internally to guide our work, but also data to use externally for things like grant applications. And so if any of these data points can be useful to you as you seek external funding, as you have conversations both inside and outside of Athens, these data are now yours to use as much as possible. So glad to share these things with you. Next slide, please. All right, so this work has been made possible by Resilient Georgia, which we've talked about multiple times in this meeting, but I want to just remind you, it's really a consortium of family foundations that have come together to fund work in behavioral health in the state of Georgia to move us forward, and particularly focusing in on birth to age 26. But we are so grateful to have funding that has made this needs assessment possible. And Athens Wellbeing Project, of course, always partnering with Envision Athens and championed by the Athens Area Community Foundation as well. Next slide. So I'm going to be giving you the introduction this morning and just a little bit of background. So this is really about informing our work as we move towards having a trauma-informed behavioral health continuum of care. This is a huge priority, not just for our county, but throughout the country and the state. This is what Resilient Georgia has really prioritized in the 2-year grant and investment that they have made in our community. And the mission is really to strive to improve birth to 26 trauma-informed practices in the Northeast Georgia region. That's really what we're focusing on doing. And to do that, our project has 5 aims. Keep going. I'm going to get those aims in just a second. So basically, what do we mean when we say having a trauma-informed continuum of care? We want to coordinate practices across systems, across sectors, across organizations. We want to advance the workforce through recruitment, education, and development, which this group is already so engaged in, not just within naloxone work, but everything else. Building awareness and a common language and understanding about adversity and resilience. Many of you have attended some of the trainings that we've done that have also been funded by this grant around understanding and sort of defining resilience and what trauma means, and then also advocating for policy and systems change. We really want to create a model that can be used in other regions and other communities across the state and across the country, because we were one of the 4 pilot sites to receive this funding. And so we're really seeking to figure out what can work at the local level to move this forward. Next slide. So we had a lot going on with the funding. One was to provide service providers with evidence-based training in our juvenile justice system, incorporating trauma-informed care into supportive services for people living in recovery, providing trauma-informed training and capacity building to 2Gen partners, offering SBIRT, which many of you have attended that training in the last year. We're going to offer that again this year. And then last but not least, what we're here today to do is to engage in a community behavioral health needs assessment. And so we have been collecting those data from households over the last 5 years. But this survey that we're presenting today was the first time that we've actually gone directly to the delivery organizations, the service providers that are providing behavioral health services on the ground, and asking you, what do you need? What are you observing? And we had to pivot really quickly, really early in the trajectory of this grant. The funding hit in January 2020. COVID hit in March of 2020. So when we designed the survey instrument, it became clear that we really needed to collect data that asked organizations not just about what their challenges and their opportunities and their strengths were in normal times, but how had that changed as a function of COVID? Because we're now operating in this post-pandemic landscape. And as we all know, that has changed how we do everything. And I think it's going to impact how we do things for a while, even though we do, by the grace of God, have some vaccinations. So I think that that's really what I want you to hear today, is that this is the first time that we've presented some of the findings from our behavioral service providers in the region. Next slide. So I'm with Athens Wellbeing Project and the College of Public Health. We wanted to marry the work that we'd already been doing and the data from Athens Wellbeing Project and the hospital systems that we worked with in 2019 to do their needs assessment with a new provider side survey in the context of COVID, which I just said. And basically what we're hoping to create here is a snapshot of the overall state of behavioral health provision and behavioral health outcomes in Northeast Georgia. So it's a tall order, but we've got some robust data to do it. Next. So in November 2020, we had a 65 question e-survey that was sent out. We offered the incentive. I got some sweet emails from people who were so excited about that Starbucks gift card. So if you completed the survey, you got the Starbucks. There's also a lot of surveys that I would gladly do for a Starbucks gift card. So we felt like that would work, and it did. We heard from 65 organizations, but it's not an organization that can respond to a survey. It's an individual. So we had more individuals than organizations respond. And many times multiple organizations or multiple individuals in an organization responded, which was wonderful. Many of you who completed it didn't want coffee. I don't know who you people are or why you operate the way you do, but that's fine. More coffee for others. And we used a convenience census sampling method. So what that means is we basically had a comprehensive list of behavioral health service providers, and we took a census approach where we tried to get everybody to respond to this survey. And in some sense, we had to kind of go with a convenience sample because it was the people responded who responded. So we didn't do any random sampling or any fancy research method stuff. It really was just us sending out a call to any and all behavioral health service providers in this region and seeing who would respond. Next slide. So I'm going to turn this over now to what's really important, and that's the data. You're going to see a lot of slides, a lot of data. We're going to move quickly. I would like to hold all questions to the end. At the end, I will facilitate some Q&A. If you feel comfortable asking that, feel free to ask that out loud, or if you would feel more comfortable having it in the chat, do that as well. If you want to ask a question and remember it and write it down in the chat now, please do, but be specific with the question so it makes sense for us to return to it in the end. And with that, I'm going to be quiet and now pass this over to Meg Bramlett, who's going to take us through the first series of data on operations, finances, telehealth, and clients. Thanks, Meg.
Thank you. All right, so we're going to walk through this sort of in the same way that we asked questions. We tried to ask kind of a bulk of questions related to a number of different topics. So the first one I'm going to talk about is operations. So the first question was, which counties does your organization serve? So whether or not you have a physical location, where are your clients coming from? As you can see, there are a number from the contiguous counties, but it's a pretty wide variety of counties that are served here. If you go to the next slide, this is a map from the St. Mary's and Piedmont Community Health Needs Assessments that were done 2 years ago. And this is the hospital service area. So you can see that, healthcare generally is regional, and the behavioral health care that we saw is reflective of that. Next slide. We then asked where there's a physical location, and you can see here, this is quite different. 60 were in Clark, and the next highest number was in Barrow with just 12. So while healthcare generally is regional, this is especially true for behavioral health. Slide. And again, okay, no, that's okay. That's okay. Thank you. Next, we just wanted to get an idea about the number of people, the size of the organization. You can see a breakdown here. The most important takeaway from this, I'd say, is about 3/4 of respondents work in an organization with less than 25 people. So as you know, smaller disruptions can have much larger impacts for smaller organizations. So this is a really important thing to keep in mind here. We did also, however, have a number of very large organizations. We got responses from hospitals and some larger systems too. So there were a variety in the responses. Next slide. Okay, we also wanted to know what kind of organization, because as we know, a lot of different healthcare providers provide behavioral health services. And there were a pretty good variety. Here it's important to note, especially down at the bottom, you can see primary or specialty private practice. About 1 in 3 here were private providers, and private providers can choose payer, which is important. They're under no obligation to accept Medicare or Medicaid, people who don't have insurance, things like that. So with such a high number of private practices, it's possible that it would be more common that certain individuals might have more trouble finding care. People who are, lower income individuals and families, older adults, and people who are out-of-pocket payers. So we started to ask then about the operational changes since COVID. As far as number of beds go, a majority of organizations had a stable number of beds and a relatively stable number of available beds. The average number of beds for respondents was 13. The median was 60, and the range was between 3 and 160. So there were a pretty wide variety of numbers of beds that people provided. And about half, a little more than half, didn't actually have any inpatient beds. They did all in-office visits, outpatient work. And then, real quick back, thank you. The demand for service here is big. So about 72% saw an overall demand increase in demand for services, which a lot of what I feel like we're going to talk about might seem intuitive and might be something you've personally experienced. But we now have this information, these data to sort of back it up. Okay, thank you. Perfect. Okay, personal protective equipment. We wanted to know about organizations' ability to receive it and how much they had on hand. So a little more than 10% had issues with PPE availability, and at the time of the survey, which was November 2020, didn't have enough on hand, they felt like. And then at the bottom, you see that more than half didn't actually experience any issues with availability and did say that they had enough. So half's not great. We'd like it to be everybody, but that was a bigger number than at least I had expected. So that was a little bit of good news. And then only 10% didn't at the time feel like they had enough PPE. So next, we wanted to ask a little bit about finances. We wanted to know about the changes in funding since the onset of the pandemic. So about 1 in 3 reported a decrease in funding opportunities. About the same amount reported a slower rate of receiving funds. And just a little bit more, almost 40% reported having difficulty getting the funds. So generally, for about a third, there were less opportunities. It came in slower and it was tougher to get. So that was a pretty big barrier that we found. Next slide. Thank you. And then also, not only were money coming in a little bit slower and a little bit tougher, about 60% said that their operational expenses, had increased during COVID. So, whether that was for technology, for PPE, for a number of different reasons, but over half of people had their operational expenses increase. And then about 41% said that their operational margins, so kind of how much cash on hand you have at the end of the month or at the end of a period, that had decreased during the pandemic. We also asked about layoffs. About 15% had to lay off at least one employee before the survey, again, which was in November 2020. And a low number, this actually represents just 2 organizations, said that they had plans to lay off employees in the next 2 months. And those 2 who had plans to do so were groups that had already previously had to lay off employees. We also asked about, under the current conditions, how long organizations could survive. So almost 70% said a year or more, which is great. We did have about 10% that said less than 6 months. And then 20% reported that they could last about 6 to 12 months under the conditions. Again, this was pre-vaccination. There were still a lot more restrictions out there. So this has likely changed, but we wanted to get a sense mid-pandemic what the effects were on these organizations.
And Meg, if I could just interject right there for a second, I think if there's anything that you see or that I've seen in the data that is concerning to me, I think this is probably it. Because if you look at, if you add together the less than 6 months and 6 to 12 months, 31.4% of our respondents saying that their organization couldn't survive more than 12 months. That is an alarming statistic, especially when you consider that we don't have enough providers already. And so we can't really stipulate, one of the things about these survey data is it really sometimes gives us more questions than answers, right? Like we can't dig right now into the why. I mean, we have some ideas. I think it's related, of course, to constrained resources, increased demand for services, and decrease in the money flowing in. But this is something I think that we've got to pay attention to. It's just the sustainability of the organizations, and almost a third of our organizations saying that they're worried they can't survive more than a year. Thanks, Meg. Keep going.
Thank you. So the big picture, kind of the takeaway here, 71% of organizations had to reduce, suspend, or discontinue services since COVID-19 started, which again, just sort of speaks to what Grace was saying, the fact that even any resources had to be cut back is major. And with the sustainability piece, this is very concerning. Okay, telehealth. Okay, so it's important to talk about kind of what telehealth is. And we used this quote on the survey. So when people were answering these questions, it was with this definition in mind. It's the use of electronic information and telecommunication technologies to support long distance clinical care, patient and professional health related education, public health and health administration. Technologies include video conferencing, the internet, store and forward imaging, streaming media, and terrestrial and wireless communication. So it's a pretty broad definition, but that's how we asked people to think about telehealth when we were asking these questions. The top 3 services that providers were providing via telehealth were individual therapy, group therapy, and provider education. Medication management was about 15%, and then there were also some psych appointments too, as well as a number of other types. But the therapies and the provider education were the main services being provided via telehealth. This was big, and I was impressed with this. So prior to COVID-19, only 30% of providers were using telehealth, and more than double do now. So 77.5% do now, which is great, because if you could go to the next slide. And a majority, 3/4 plan to continue using it after the pandemic. Okay, next slide. Oh, sorry, I must have changed the order. We also asked some qualitative questions here. So we wanted to give folks the opportunity to tell us how telemedicine has affected their quality of care. Next slide. We pulled some quotes from the responses. So there were some positive and some negatives. So recovery is based on community. So right, if you're providing group services remotely, you lose that togetherness, which makes sense. But then on the flip side, it expanded capacity, it helps alleviate transportation issues, and gives better access to people who might not have had it in the past. And, from the provider standpoint, reducing no-show rates, that's important to consider as well. Next slide. So also making it easier to increase the footprint. So, again, with the access and the transportation, it's a lot easier for you to serve somebody who's 8 counties away if nobody has to work on getting that transportation there. There is a decrease in the ability for oversight checks. Again, that kind of person-to-person, face-to-face interaction, which can interfere with medication compliance. So that's an important point to consider. So here we go. So the overall takeaway is that more telehealth leads to more access for rural and low income populations. And while it's not necessarily the be all end all substitute, the fact that 3/4 are talking about incorporating it and continuing to incorporate it is probably pretty good news for people who are struggling with access to behavioral health services. Okay, we asked then about the client population. As you can see here, the dark blue is an increase in issues. So the top were fear, anxiety, and loneliness. These are what people were seeing in their clients. And it moves progressively lower to the right, but there was still an increase in rates of suicide, PTSD, intimate partner violence. So while they weren't as high, there was still overall, people were seeing an increase in these issues. And again, this wasn't terribly surprising, but to see it quantified is important. Next slide. 100% of respondents said that they had seen an increase in at least one of these symptoms or behaviors. Nobody said everything stayed the same. And 1 in 3 respondents said that they had seen an increase in all of these symptoms or behaviors. Okay, I'm going to hand it over to Harrison. Thanks y'all so much.
Absolutely. And we were also interested in learning more about medication-assisted treatment and naloxone use from our providers. Next slide. So just to kind of prime you guys about this, medication-assisted treatment, if you don't know, we also call it MAT, and it refers to the use of medication, often in conjunction with different other therapies and counseling to treat substance use disorders. Currently by the FDA, there are 3 medications approved. I can't pronounce them, but you can read them. So next slide. And also naloxone use obviously is of huge interest to this group in particular right now. It's brand name under Narcan, and it's a medication used in emergencies to treat opioid overdoses. Next slide. And so this slide here is looking particularly at kind of the overlap between organizations that provide naloxone and MAT. And so what we see is 12 organizations, or 17%, provide both naloxone and MAT currently. 4 organizations, or 6%, offer MAT but not naloxone, and 9 organizations, or 13%, offer naloxone but not MAT. And this refers to their current offerings as of when the survey was conducted, which is in November and December of 2020. So next slide. And so what we're looking at here is specifically MAT and the way that it changed over the course of COVID. Originally, all organizations, that is 14% of respondents that offered MAT before COVID-19, continue to offer MAT now. In contrast, all the organizations that did not offer MAT prior to COVID-19 continue to not offer MAT today. And so what we see is essentially no net change in the number of providers who offer MAT. But what we'll see in a couple of slides is that the organizations that do offer MAT now oftentimes have an easier way and method of actually administering it by some recent changes due to COVID by SAMHSA. Next slide. And so now turning our attention to naloxone, 18, and so this is kind of the same thing where we're looking at the changes due to COVID-19. So 18 organizations, or 25% of respondents, offered naloxone both prior to COVID-19, and they still currently do. 3 organizations who did not offer naloxone before COVID-19 now do. 2 organizations that did offer COVID-19 that did offer naloxone before COVID-19 now do not offer naloxone. And so what we see here is a net change of essentially 1 provider gained in who offers naloxone. So 21 currently offer naloxone, and 20 offer naloxone before COVID-19. Next slide. Okay. And then so turning our attention over to some of these qualitative responses, one thing that we were interested in is changes in MAT administration policies and procedures for the organizations that do offer MAT. Next slide. And so what we see here is, so over the course of COVID-19, SAMHSA, which is essentially the national government body that kind of oversees MAT, loosened some of the guidelines and requirements for MAT distribution and prescriptions. And so we see now offering telehealth individual and group sessions, federal exception allowing more take-home medication to clients, as well as patients who are more stable were able to receive increased take-home doses in order to minimize traffic inside the facility. And so for these organizations that did offer MAT, it was a lot easier for them to offer the program to their clients. Next slide. All right, so please explain barriers you are experiencing that prohibit your organization from providing MAT. And so this is obviously interested in the organizations that currently don't and why they can't do it. So next slide. So lack of funding and training on best practices and processes. And we do not offer any services through our program. We are open to linking our participants to these services. And so there seems to be a bit of a disconnect between the ability to provide MAT and kind of what's needed to actually do it. And so lowering the barriers and lowering the boundaries to actually access the program and be able to provide it to clients is pretty essential moving forward. Next slide. And so looking kind of more at the big picture, what we see is that 18% of respondents offered either MAT or naloxone, and 17% offer both MAT and naloxone currently. And so in total, about 35% of our respondents offer either MAT or naloxone or both at the same time currently. And so due to COVID-19, we only saw a net change of one provider that was increased in terms of naloxone use, but no change in terms of MAT use. Next slide. And so 21% of organizations that do not currently offer MAT said that they were willing to offer MAT in the future. And so these are organizations that we know, that we can recognize, and that we can work on facilitating the actual process of learning how to offer it and what barriers that need to be overcome in order to do so. Next slide. And so turning our attention now over to some of the more open-ended and qualitative responses generally. Next slide. And so just to kind of prime yourself about this, qualitative data and these questions were those that allowed for free form and open answers for respondents to express their thoughts and allow for a lot more in-depth answers and anecdotes about their experiences. And so we had 12 of these on this needs assessment. Some of these we went through previously, and the rest we'll go through now. Next slide. And so before we get into them, I kind of want to draw your attention to some of these themes that we saw pop up over and over again in our responses. So first we see anxiety, depression, and stress. All of these, like we talked about before, are increasing, and over 50% of these open-ended responses mention one of these three. And the vast majority of time, these were often mentioned in conjunction with one another. And then so turning your attention to kind of the middle one, isolation, fear, and feeling overwhelmed. About 1 in 3 respondents mentioned these. And these were specifically related both to client and employee morale and demeanor. And so these are situations that don't just affect the clients of our providers, but our providers themselves and the employees of these organizations. And for our providers, what we see a lot of is specifically compassion fatigue and recognition, where a lot of the times, they're doing such incredible work and important work, but it's hard to feel recognized in the community when there are so many other things going on. And so it's important that we acknowledge the work that our providers are doing in caring for the mental health of their clients. And in terms of operations, we see a lot of issues with virtual challenges, obviously all the telehealth stuff going on, as well as the need for increased language access in Athens, specifically Spanish. So next slide. So this first question, how have the needs or presenting problems of your behavioral health clients changed since COVID-19? So this is focusing particularly on the clients. Next slide. And so just drawing out a couple of quotes: increase in depression, anxiety, marital stress, grief, and addictions, more people requesting counseling for their children, many grieving the lives they once had. Many clients are dealing with increasing bills, loss of jobs, or jobs with reduced hours, which is creating depression and hopelessness. Many have lost loved ones due to COVID. This is fueling relapse. And so these are just 2 quotes that we pulled out that we thought were particularly powerful in talking about the way that their clients have responded to COVID-19 and a lot of the struggles that they've had so far. Next slide. And so this question is more focused on specifically the providers and employees of each organization and their morale. Next slide. Our morale has waxed and waned. We have experienced the need to be more proactively supportive of employees' mental health and trauma needs. We are trying to balance increased demands with employees' self-care needs and support needs. Overall, we are carefully monitoring staff morale. It is fragile during these times. It has been a difficult year of uncertainty, flexibility, and chronic stress that is impacting our ability to serve others well. And so what we see from our providers is much of the same as the clients, where their mental health isn't immune to the pandemic and everything going on right now. And as a result of it, it can impact the care that they're providing. And so it's critical that we continue to lean on each other and support each other in terms of taking care of ourselves as well as our clients during this time. Next slide. And so turning over to kind of more generally, please describe the two greatest challenges your organization is currently facing. Next slide. All right, so uncertainty about what the coming months hold has made it very difficult to plan grants and spending, as well as work plans for next year. Internally, the lack of morale and uncertainty has created barriers for our clinic to engage and re-engage patients. Recruiting and hiring and keeping staff is a huge challenge. And so what we see here is staffing issues, which is something that, I didn't necessarily anticipate in the beginning, but it completely makes total sense where, right, coupled with financial concerns, as well as people, burning out during the course of the pandemic, it's really hard to keep and retain staff as well as to hire staff during this time when there's so much uncertainty and there's so much chaos going on. For our organizations that are dealing with it, it's important that we kind of make sure that they continue to feel supported and that we continue to try to make sure that staff can stay on over long periods of time. Next slide. All right, and so just this last question, we just pulled one quote from here. What else do we need to know about the behavioral health needs of our community? Next slide. The effects of the pandemic are going to be long lasting and widespread. People's mental health is being placed at risk alongside those providing the care. There will need to be additional attention and funds given to community mental health in an already understaffed and exhausted system. So this quote I thought was particularly poignant and pointing out a lot of what we're dealing with today, and understanding that even though there might be that we see that this light at the end of the tunnel, a little glimmer of hope, there is a lot of additional attention and need that needs to be paid attention to our mental health in the coming months and foreseeable future for both clients and providers. And with that said, I'll turn it back over to Dr. Adams to wrap this up.
Harrison and Meg, you did a beautiful job. I want to pause for just a second and kind of just say a couple of things to tie everything together and then acknowledge those who have really made this possible. The first is that, all the measurements that we have of patient level outcomes are really pre-COVID right now. We have some initial indications knowing it from some state and national data, but not local data yet. But some state and national data are showing us that relapse and overdose are going to be really have experienced some profound increases in the last year, and increases in depression, anxiety as a result of the pandemic, and a lot of the economic hardship. But we're going to be in the field with Athens Wellbeing Project in the fall of 2021 of this year to be able to measure that at the local level. So it's going to be important to be able to have those baseline data that we already have so we can measure change. I think that the negative things, like the things that are really concerning that come out of the data to me, really link back to sustainability, right? Like the ability of our organizations that we have to stay open. Retention of each individual service provider is so critical, and we don't have enough already. And so really being concerned about the sustainability and thinking about what we can do to support the retention of employees, but the retention of organizations as a whole is going to be really critical. I think the two positive things that we've seen really are around telehealth and medication assisted treatment. I mean, if you look at the resiliency of the organizations and the flexibility that each of you have demonstrated in this pandemic to expand services and offer services over the phone or over video appointments, just as an example, I mean, that has been transformational and opens up access on a whole new level that we haven't seen before. And I think that the plans of the organizations, as they were expressed in this survey, to continue doing that is profound and positive and a wonderful way to start closing the gap on some of the health disparities that we have in this county, not just for behavioral health, but more broadly health in general. And then just looking at that 20% of you all that were willing to think about expanding services for MAT, that is a big win too. So, ability and willingness to grow medication assisted treatment in this community, because it's a pretty small landscape right now, but ability and willingness to grow that. And then the expanded flexibility that the federal government has given for offerings of MAT due to COVID that I think will stay in place for a little while at least, are all positive things. So let's just close on gratitude and that positive note. So thank you to Sarah McKinney. She couldn't be with us today, but she's the president and CEO of the Athens Area Community Foundation. It really makes all of this work possible through AWP and the leadership and championing of that work. Aaron, thank you for having us today. And John, thank you so much for your support as we prepared for today. Jacob, Meg, Harrison, and Meredith, they did this work. We collected the data and I helped develop the survey, but they did the analysis that you see today while I was on maternity leave. They have pulled the weight and you have done a beautiful job. Thank you so much. And just finally, again, thank you to Resilient Georgia and the Potomac Foundation for funding the work. By some Christmas miracle, we have about 5 minutes, I think, for Q&A. And so I want to facilitate some of that now. So we can X out of the slides, John, so that I can just see everyone's wonderful faces. There's our email addresses. Those will be also in the notes that John sends out today. So if you have questions or if you've watched the recording and you have questions and want to ask us for the data, for the slides, for clarifications on what you've seen, please feel free to email Meg or I. And with that, I'll open it up to questions. Anybody on my team, probably everybody else is more equipped to take them than me. So we're ready to take your questions.
Harrison, I know there was a question from both Chaplain Napper and I about the naloxone dip. There were 2 organizations. Any idea or indication given as to why and if there's follow-up opportunity there?
Yes. You got
Harrison,
it.
did we have an open-ended question on that as to why they stopped?
So we did not, I believe, but we do have access to who those organizations were, and we can definitely reach out to them and ask.
Yeah, so in that sense, the anonymity of the individual respondent, of the person who responded, we don't know those data. We didn't keep those data or track those or link those to the responses, but we do know the organization from which the response came. And so the reason that we did that, again, strategically, was so that we could use it for planning and policy purposes. And so that, Aaron, is something that we certainly can share.
Perfect, thanks.
I would say that in addition to the organizations who said that they don't currently, but want to, I think those were sort of the 2 areas where we specifically intend to do some outreach soon.
And I know we want to focus this time on questions, but I think a clear action opportunity was for sure in that category of the 2 naloxone decrease, and then the opportunity in following up with the MAT interested organization. So can we maybe have an offline conversation about that and follow up?
Absolutely.
Thanks.
I've got a list ready for you.
I thought you might. Thanks. What other questions? Miss Linda Davis asks, is there any indication of unmet needs in this area?
Ms. Davis, could you clarify unmet needs of the organizations or of patients, or both?
Patients. Mostly patients.
Yeah, so I think that there are, broadly 2 categories, right? What we're dealing with is we have a lot of folks, 33% of our Athens Wellbeing Project respondents indicate that they needed mental health treatment in the last year but couldn't get it. And that's mental health treatment. I realize behavioral health is broader, but it includes mental health. So I think one of the greatest unmet needs is simply the patients who need services but are not getting them at all. Okay, I think that's one of the biggest issues. And in the follow-up question that we asked on the AWP survey about that, we asked why. And the biggest issues, plural, there are a plurality of things often that create a perfect storm, but typically it's affordability, lack of access, or being underinsured, not being able to get the time off work to get the services. And for males in our community, it's stigma, not really wanting to get the help and the treatment, the medical treatment they need for a medical condition, because there is still stigma around mental and behavioral health issues. And so that's kind of a combination that, as I said, often creates a perfect storm. Now, there are other reasons why people don't access mental health issues. Sometimes people say or mental health when they need it, care. Sometimes people say they're just simply not ready to do so. So they recognize that they need it, but they're not really ready to get the help that they need. I think that there are certainly opportunities that are connected to getting that particular group of people access, especially around addressing the affordability and the stigma. I think that's where we can intervene in terms of community engagement opportunities to help that. There's another group of people who is accessing the services that they need, but maybe not to the extent that they need them, right? So it could be that, folks are getting, for example, the therapy that they need, but they can't get access to the medications that they need, because there are multiple kinds of services that patients often need when they are faced with mental or behavioral health challenges. It's not just sort of a one and done kind of deal, right? So even though you're getting services, it could be that you're not getting the extent of the services that you need, or maybe there's not a great match between the client and the provider. So it's very complex. So I think the biggest unmet needs are A, the folks who aren't getting any services that need them, and B, the folks who are getting services but still not to the extent that they really need that wraparound support. And I think in addition to that, in the behavioral health community, especially for folks with substance use disorder, I think one of the biggest unmet needs is for the family members and the loved ones of people who are undergoing treatment, or who are faced with the illness, who aren't getting treatment. But that there's a tremendous amount of stress and strain on the loved ones that often goes unaddressed. And I think that's also sort of a third category.
I would just say in addition to that, and we talked about it, but the toll that it takes on the providers is just kind of another, it's peripheral, but it does impact everything. So whether people can stay in the business, whether people burn out, things like that. So it's all related, but that was something we heard: burnout and compassion fatigue a lot.
I just want to note that the mayor and commission is having a work session tomorrow evening to begin conversations about the rescue dollars that will be available in Athens, Clarke County. And so I think we each have an opportunity, and given our, I think, unique understanding about this particular crisis, the obligation to follow up with elected officials and note that we have specific people in need of a very important rescue for a problem that's only getting worse. Grace, I just want to reiterate your point too. Ms. Davis, thank you for your question. And, we're relying on the responses of service providers. And I think that's really critical and valuable information as AWP goes back into the field this fall. I think it will be interesting to dig even more deeply on that individuated person level to kind of hear what are people saying about that. So I look forward to more information then.
Thank you, Erin. I think the punchline, not just for organizations, but for families, is that every single one of us has had to do more with less this past year, and that goes for the services that are provided, that goes for our time, our money, our employment opportunities. I mean, basically on every front. And so I think the outcome, of course, that we're seeing show up in this survey: compassion fatigue, burnout on the service provider side. And then I saw Tiffany typed here, we've been busier than ever before this past year. You've had more demand on you and your time and your services, but you haven't really had a huge influx of more people or money to do the work with, right? And so, that just creates a really stressful, difficult situation.
If we could pause there for a moment. There are so many findings and insights from this presentation, and thank you again, Dr. Adams and team for this insight. Because of who's gathered here today, I want to stop and maybe end on the question. I'm highly disturbed and not surprised at the reported lower levels of morale and the stress and strain on you and our colleagues. I would love your thoughts if you have them now, and I would love to ask you to think about this between now and our next time together. What are potential responses to help us address and increase morale? I do think that's an area where some of the solutions can be found within this group, and I would love to be a part of helping us move in that direction. I think at some point when it's safe, I think that there will be incredible qualitative benefits to coming back together physically. So when we can do that, I think that's key. But I just want to open us up for that. If anyone has any thoughts and specific needs that you have.
Can you hear me?
Yes.
Okay. I'm using a desktop, so I had to plug in an old school microphone. With my staff in the beginning, I tried to keep things, because they're sitting with heavy all day long. So we're a counseling agency, so we're hearing all these issues all day long. And so I would put up each day, a little joke for the day. It might be a therapy related joke, but a little joke for the day. And then I would do like little notes in their boxes just to let them know, I really appreciate everything you're doing for our community. I would leave little messages for them, or I'd encourage them to kind of lift each other up. We have our staff meetings. Some people are virtual. Some people are here in a large conference room. So it's not as intimate as it used to be, but trying to have a structure for it, as well as creating a space where we could have those discussions about, yeah, this is hard. So we're having parallel processes. We're experiencing the pandemic at the same time as our clients are. So we are sitting with the anxiety, we are sitting with the uncertainty, and we're trying to provide them with comfort as we're needing to comfort each other in the process. So we've just created that space to be able to have some of those conversations. So some of our staff meetings weren't very business minded. They were more about process and where are we at and how can we support each other.
Thank you. And Tiffany, as you've made time and prioritized kind of lifting up the hands of your colleagues, my question for you all between now and our next meeting is there anything that Envision and we can do to hold up your hands? So just be thinking about that, and how, as we do make plans to come back together, might we reshape that time and think about how to just be real and make space for conversations that you all might need to have in order to continue to do the work that you're being tasked with. Let's see, Patrick. Patrick, can you share a little bit more about your question? So Patrick notes in the chat box, I think the question is, has attention to the need for funding increased because of the pandemic?
I think, from a behavioral health perspective, what we have seen is more attention on the prevalence of behavioral health illness and issues, definitely. I hope that leads to the realization and understanding that means that we need more funding to address, the needs of not just our patients, but our organizations and our providers. But I think, to Erin's point, a lot of those conversations are now happening where we're seeing state and federal dollars flow through. So we're going to have to be really diligent about making sure that our elected officials understand the need for those resources and increased support at this most critical time, because just because we have vaccinations, I mean, as you all know, this is the tip of the iceberg. This is now the beginning of the work where we are going to be addressing the collateral damage done by the pandemic for many, many decades to come. So I think that's we've got a lot of work to do now as behavioral health providers and advocates to kind of draw that line, that causal line. And thank you for Patrick's question, between the needs that we observe in our patients and our organizations and the funds that are available to address those needs.
Fantastic. Thanks so much. I know that there are likely questions that remain, and Dr. Adams and Meg, thanks for sharing your email address. Our next meeting, everyone, is May 12th, which is a Wednesday, of course, at 10 a.m. So thank you so much for your time today. Thanks again for the heavy lifting of this data gathering and analysis and presenting. Meredith, Meg, Harrison, John, Jacob, Grace, thank you.
Thank y'all so much for having us today.
Thanks a lot. Please remember, as you take care of others, please take care of yourself and know that you are highly valued. Have a great day.